I don't know if all of you have met Dr. Eschelbach. Dr. Eschelbach is our assistant medical director for the state of Oregon. He teaches for us quite frequently, usually at least once a month. And he also teaches up on the circuit there in EMS in that section of the United States. He's the medical director for the hospital there at Redmond, Oregon, and very, very EMS friendly and EMS active. So his lectures are always very timely and always something that will help fill in some gaps for some of you. So listen closely. Now remember, you will have to participate. Keep your microphones on mute, unless you have a question. And then if you have a question, you can unmute and say, hey, Doc, I have a question. Or you can type into the chat, but it's kind of hard sometimes when the doc's on a roll for him to see the stuff in the chat room. So it's better sometimes if you hit the microphone and stop, or just type in the chat, and then whenever Dr. Eschelbach gets to a breaking point, we can look through and try to catch those answers up for your questions. You do have to participate if you need credit. We encourage all to participate, but for you paramedic students, for your MD Roundtable credit, you do have to participate. You still have to be here. If you're on 911 duty and you get a call, you can just type 911 down in the chat box, and depending upon how long you've been here and whether or not you participated as to whether or not you'll get the credit. If you are full on the MD Roundtable credit, or you're like Nathaniel from a different class, then I have no objection to give you chat room credit as long as you participate. That having been said, I'm going to turn you over to Dr. Matt.
All right, good evening, everyone. As Jane said, this is a timely topic, and I like to try and do this lecture at least once a year or every other year, because it's one that does warrant some review, and there's usually a couple questions on your board tests when it happens. So I'm going to go ahead and start the talk. Drowning, and you'll see near drowning, I put that in parentheses because that's really an older term, is quite still a problematic medical condition. This is, I'm in the state of Oregon, and I'm sure if you were to look up your state, and maybe Google it and look for it, you would find very similar numbers. I recently, this was published a few years back in the state of Oregon, and looked for an updated number, and they really hadn't provided anybody a new number. But what you'll see is what we call a bimodal distribution of deaths from drowning. You'll see that males far outweigh females, and that is usually just plain Darwinian type of distribution, because males tend to do riskier things than females. And you'll also notice that there's quite a bit of peak here in the age group between 15 and 35 years of age for males as well. You'll also note that of all comers, that there's a peak for young, very young, and we'll talk about that. And then there's the teenagers who drowned, and then they peak up again later in life. Older people, we'll talk about that at the end. This data has not changed significantly. That's why the numbers appear old, even though it's relatively the same each month. About 1,000 kids less than 14 years of age will drown each year. And in 2000, there were about 3,200 unintentional drownings in the United States, about 9 people a day. And that was not including boating related incidents. In 2003, there was for every child who drowns, 3 will need emergency department care, and 40% of these children will require some form of hospitalization. Now, drowning is a process of primary respiratory impairment from submersion in a liquid medium. That could mean water, as it is most of the time, fresh water versus salt water. And this is regardless of survival. So a drowning or what we call near drowning event are the same. And drowning without aspiration just does not occur. And I'll talk about that a little bit later. Terms which are out are dry drowning versus wet drowning or near drowning. But you'll still hear people talk about these terms. Most of the time, near drowning will be talked about when a patient survives. So even though they have drowned, they don't die and they survive. And that is most synonymous with near drowning. Now, this is, again, the state of Oregon, but if you look for your state, you'll probably see a similar distribution. Keep in mind that Oregon is a coastal state. So over here on the western aspect of the state is the Pacific Ocean. And over here on the eastern aspect of our state is next to Idaho, mostly river. And the county where I live here in the middle of the state, in Deschutes County, has got quite a bit of recreation, quite a few. There's a mountain range in Oregon that goes right here, and there are quite a few what we call high lakes, clear water lakes that are there year-round, and quite a bit of drowning occurs in high lakes. If you were to look at your own state, you would probably see a similar distribution, whether it is coastal, recreational, or again, riparian or river associated. The groups that are risk, again, 78% of the drownings in the United States are males. Children, about 1,000 or 900 per year, although they have slowly declined because parents are a little bit more apt to look for children, and there's quite a few more safety things going on. I'll talk about those in a few minutes. It's the second leading cause of injury-related death from kids 1 to 14 years of age, trauma being the first. And there's still an abnormal distribution of African Americans or Black Americans, and it seems to be about 1.4% higher than the general population. No actual reason for this other than supposed exposure to pools and learning as a child, and perhaps city versus urban distribution. 15% of the children admitted to the hospital will actually wind up dying, and we'll talk about a little bit about that as well. And as many as 20% of drowning survivors have some form of severe permanent neurologic disability. So that's 1 in 5. Infants, children less than 1 year of age, are usually victims of bathtub drowning, buckets and toilets, which I'll talk about in a few moments, and 1 to 4 years, swimming pools, hot tubs, and spas, and children 5 to 14, usually swimming pools and open water sites. Now, bucket drownings, about 300 per year since 1984. Many of us have these buckets around. If you go to Home Depot, they'll encourage you to take home a bucket and buy a bucket. And we tend to put our tools in them and everything else. So we have painting, leftover buckets, and probably if I were to look at my own household, I probably have a dozen of these types of buckets with various things in them. Bucket drownings occur in the toddler range, where they're just starting to walk, 7 months to 15 months of age. And these buckets are usually 24 to 31 inches tall, and they can contain water, they can contain paint, turpentine, cleaning fluid. And as you recall, children have large heads in comparison to the rest of their body, so they're weighted heavily. So if they put their head in the bucket, it's near impossible for them to get it out. Tub drownings do occur. That makes up about 10% of childhood drownings. And it's usually because of adult supervision is lacking. Very often they'll have bath rings or tub seats, and moms don't realize that they are dangerous. The child will be just a few minutes, mom or dad will just walk away for a few minutes, and a drowning can occur. So, bathtub seats and bath rings, I did, I'm an ER physician, and yet I had them, but you always had to kind of sit there while kids were taking a bath, because they could fall over. They're not safety devices. They will keep a kid from minimally tipping over. But again, if you put too much faith in them, you can get caught. There's usually about 40 drownings per year from these bathtub rings. 45% of infants in this age group will use bath seats, and data suggests that either having them have either no effect or very slight protection. But again, you have to have an adult sitting right next to the tub at all times. A lot of moms and dads go to baby swim classes, and they're actually, the teaching is mostly so children learn how to float, to try and teach them to learn to lay on their back and float. There have been no reported drownings in class, but there have been seizures, and that's because the children tend to drink the water and wind up with hyponatremia or low sodium, and that can be a side effect of these classes. And does it cause a false sense of security? Perhaps so. One of my favorite pictures from album cover is this, Nirvana, or another album cover from Weird Al. So let's move up to a little bit older children, pool and spa drownings. Um, these are children usually less than 4 years in the 1 to 4 year category. There are about 3,000 a year where a child will need some form of hospital treatment. These are our near misses, which we happen to see quite frequently. Most of the time, the child was last seen in the home. Children are missing from sight less than 5 minutes, and they're usually under the care of one or both parents at the time of the drowning. Greater than 50% of the time, it's the home pool where it happens. And 1/3 will happen at homes of friends, neighbors, or family. And since 1980, about 230 kids per year will die in a hot tub or a spa. There have been studies to see if pool fencing is helpful, and it is, in fact, pool fencing will significantly reduce the risk of drowning. And isolation fencing, including the pool only, is superior to perimeter fencing. Perimeter fencing will keep neighboring children out, but if you live in the home, you still have access to the pool itself. In-ground swimming pools without complete four-sided isolation fencing are 60% more likely to be involved in drowning than four-sided isolation fencing. So it will protect, it's better when it's around the pool as opposed to around the property. Boat-related drownings, the Coast Guard has released info for all ages, and 70% of the fatalities from boat-related injuries is from drowning, 30% from trauma, hypothermia, carbon monoxide poisoning, and alcohol was involved in about 40% of the fatalities. And again, that's that bimodal distribution, more likely males than females. But alcohol, of course, does not mix with operating a vehicle. And the first thing we do if we're on a hot boat in a hot day is to try and drink something, and a cool beer or something like that is the most likely. Open motorboats are more than personal watercraft. And again, most of the time it happens because people fail to wear life jackets. Alcohol is involved of up to half of teen and adult deaths associated with water recreation. It influences the balance, the coordination, judgment, obviously, and the effects are heightened by sun exposure and heat. The relative risk of drowning increased to 31.8 with alcohol levels greater than 21 millimoles. That's probably akin to a 0.8, which is where deweys occur. This is one way of looking at the sequence of drowning. Very often there is a struggle and then breath holding. And when you can't hold your breath anymore, there is some gasping, which can lead to vomiting or aspiration, or some form of laryngospasm, or they just plain swallow water. This dry drowning does really not occur, and you lose your reflexes, and then you just wind up letting water into your lungs. So the event of drowning itself, there's the voluntary breath holding, uh, small amounts of aspiration into the larynx, followed by laryngospasm and coughing, where then large amounts of water can be swallowed. Eventually, that laryngospasm abates because you don't have enough oxygen in your blood and you aspirate into your lungs. This will lead to a decrease in saturations, decrease in cardiac output. You get a intense peripheral vasoconstriction, which will try and bump up your blood pressure. You begin to get hypothermic and cold, then bradycardic, and then eventually circulatory arrest. While VFib is rare, most often it'll lead to a PEA type of arrangement. And then you get extravascular fluid shifts and problems with sodium, potassium, etc., while the heart is still beating. There is something called diving reflex, which can help some people. It's a bradycardia followed by an apnea or stopping of breathing and a vasoconstriction. It's very, very weak in humans. It is better in children, however. And this diving reflex we'll hear about once every few years when we're talking about typically cold water drownings. A child who drowned in Lake Michigan in the middle of winter, for example, where they've been under for 50 minutes and eventually someone finds them and they survive. It can happen when just the face is submerged. And if you think of other mammals, such as seals and whales, it happens in those animals when they go deep into colder water. They're to hunt, for example, their breathing slows down quite a bit. The extent of neurologic protection in humans due to the diving reflex is likely very minimal, but we'll hear about it every year. Continue on with the effect of drowning. You wind up with this asphyxia and hypoxemia, too much CO2 and hypercarbia, and then you wind up with a metabolic acidosis, which usually contributes to the PEA rhythm that you'll find. Fresh water versus salt water, there's very little difference except in very high mineral content like the Dead Sea, and there's quite a bit more trauma to the lungs then. There is this hypoxemia, which is a lack of oxygen, and you wind up with particulate debris in the lungs themselves. For example, you'll find in fresh water what we call diatomaceous earth, or the diatoms in the lungs, which will get rid of the surfactant activity, which expands the lungs, the bronchospasm, and you wind up with a right to left shunting of the heart and lungs, and your dead sprays disappears. This is usually followed by cardiac arrhythmias, most likely PEA. You can wind up with an encephalopathy, which is a brain problem from lack of oxygen. Kidneys can shut down, and you can get cerebral edema or swelling of the brain. So you might have somebody who's a near drowning victim, again, somebody who drowned, and maybe you rescue them. 75% of the children who develop symptoms do so within 7 hours of the event. So what I usually counsel parents when I see these children in the ER is I either outright admit them to the hospital where they can be monitored, or we keep them in the ER, for 7, 8 hours at a time. Sometimes there is a coma and cyanosis. We'll see very often this frothy pink sputum, the one that you might see with congestive heart failure. You'll see that because there's been injury to the small alveoli. Very often they're breathing quickly and they're tachycardic. A low-grade fever may occur, and they might have, rales and rhonchi. And you have to look for associated trauma, which I'll talk about in a few moments. So pre-hospital treatment for these drowning victims, rapid and cautious retrieval from the water. Think safety first. I'll give you a little case history at the end, where we wound up with some hypothermia. Establish the airway, ABC with seed spine precautions. Very often, these are diving related injuries where someone jumps in, hits the top of their head, and might wind up with a C-spine injury. Breathing, initially mouth to mouth, could be done. Bag valve mask or assisted ventilations are important. And then you may need to intubate depending on how alert they are. But supplemental oxygen in all patients. The abdominal thrust is somewhat controversial, but people will usually lay a patient on their side for gravitational drainage at least. This can lead to delays in ventilation and transport if people are spending too much time trying to do abdominal thrusts. And it can lead to regurgitation or vomiting and pulmonary aspiration if people are on their back. So sometimes putting them on their side, if they're conscious or semi-conscious, is a good idea. If they are not spontaneously breathing, good CPR and assessing the situation is a good idea, because this will actually force air into the lungs and reestablish the circulation, and then transport as soon as possible. Any patient with a significant episode, including those who are now asymptomatic at the scene, should probably be transported to the hospital for evaluation. We're not talking 10 seconds of somebody flailing, but if there's somebody who's had a rescue, you should probably transport these patients and explain to the family that you can see delay in up to 8 hours in the lungs of drowning victims. CPR in the water is generally ineffective and dangerous, so it's best to try and get the patient out of the water and begin CPR. And near drowning victims very often aspirate small quantities of water. So the postural drainage we talked about, turning them on their side, it's unproven, but it sometimes helps stimulate the coughing that we need to see to drain the lungs. If you look at drowning victims, you'll find that there's a very high percent of associated trauma. This is a picture, X-ray of a cervical fracture that happened when a boy jumped off a diving board and hit the top of his head, causing a hyperextension injury with a cervical fracture. So you'll find that the majority of the time, again, that these are males, and sometimes there's pre-existing disease like arthritis or something like that. But very, very often there are associated traumatic injuries that actually led to the drowning. It could be a head injury where they hit their head or something to that effect. The therapy for the lungs, CPAP or PEEP may be very good for those people who are near drowning and who are now gasping for air. Bronchospasm can be taken care of by your regular albuterol or duoneb, beta agonists. A pulmonary specialist may want to do a bronchoscopy because very often it's in a shallow water with lots of algae and other particulates, and they might want to lavage the lungs and clean out the lungs. Antibiotics have not been shown to be beneficial. Very often there's a fever response, which doesn't necessarily mean a pneumonia, but if you look at this chest x-ray of a drowning victim, they look almost like a pneumonia or a congestive heart failure, and that's due to the local trauma to the lung tissue. Steroids have not been shown to be good. So if you have in your protocols, some people have methylprednisolone for severe bronchospasm in their protocols. Steroids really do not help. Bad prognostic indicators. If you're submerged greater than 10 minutes or the time before basic life support is greater than 10 minutes, that's a bad indicator. If CPR has been going on for greater than 25 minutes, that's not good. If the initial GCS is less than 5, age less than 3 years, and if CPR continues into the ER, and then by that time we're getting labs and initial blood pH is usually less than 7.1, and a core temperature of less than 33 is actually a bad prognostic sign. Even though we talked about the diving reflex and cold water drownings, those are relatively rare. But people who do survive with prolonged exposure to water are usually hypothermic due to that diving reflex. So it's kind of a double-edged sword there. Will the child die? Well, in the emergency department, if we have a normal lung examination, mortality is generally 0. If they've got some minimal wheezing or abnormal lung exam, usually that's less than 1. If they have pulmonary edema early on, you'll see that mortality can be 5%. Low blood pressure, hypotension, and pulmonary edema, 20%. And then if they had respiratory arrest and they needed to be intubated, up to half of those people can die from the drowning. And if they had cardiopulmonary arrest, like a PEA rhythm, up to 90% of those folks can die. The neurologic problems, like an absence of spontaneous respirations, it's an ominous sign of neurologic problem. There might be a permanent, even though the patient survived, permanent neurologic problem can persist in up to 20% of the victims, leading from minimal brain dysfunction to severe neuromuscular problems. Again, cold versus icy water immersion. Um, as I said, hypothermia is an unfavorable sign. Several cases will show, like we said, you'll get that case in the news once every 2 or 3 years about cold water submersion and people living, but those are relatively rare. For hypothermia to be protective, um, the body temperature has to fall very rapidly. So this has to be in freezing, a fall from through the ice in near freezing water. And that's about the only time you'll get that protective effect happening. Hypothermia, that being said, is a little bit easier in kids because they have a body surface area to mass ratio with less fat. So they can become hypothermic sooner. And moderate and severe hypothermia, less than 32, is where you're going to have that severe hypothermia very, very quickly to have a neurologic outcome that's favorable. When this does happen, the effect of protecting the brain and the organs themselves in up to 110 minutes in some instances, the body core temperature was quickly cooled. They have done some studies with this, quickly cooling the body with animals and animal studies, pigs and dogs. And that is when this effect quickly happens. But once cell death happens, there's no protection from hypothermia. So that's why most warm water drownings, especially in kids, are not very good at all. Surface cooling alone cannot decrease the core temperature fast enough to yield protection. It's hard to figure out exactly what happens, but a child will probably have to fall through extremely cold water and then quickly drown. And then by quickly bringing in this cold water and aspirating the cold water, you would get some possible protection. The hypothermic protection involving surface cooling only would have to happen in icy water. There's still, again, you'll hear every year of one of these children surviving. But again, hypothermia is an unfavorable prognostic sign. And in several studies, there just have not been good survival rates with drowning in general, no matter what the temperature. Now we're going back to the drowning victim and resuscitation. If you're trying to rewarm these people, you're going to try and rewarm them just like you did when we talked about hypothermia. With mild, that's passive rewarming, warm blankets and heat, ambient heat. When moderate happens and shivering fails, you might need to use some internal rewarming like warmed IV. And with severe hypothermia, this is where you can get that V-fib. You might need to put in core body heat, such as doing IVs with warm fluids, putting in nasogastric tube, and putting warm water into the esophagus and stomach, and rectal warming as well. They have done some research into warm water drownings. They studied drownings from 6 months to 15 years. And again, surprise, surprise, mostly males. The submersion was witnessed in only 10 to 12% of the cases. And most, again, backyard pools, spas, bathtubs, lakes, or ponds are the most common sites. People who survived had bystander resuscitation, basic ABCs done to them. Response time was low, 6.8 minutes. Very often with these people, the children were in cardiac arrests, and the most common rhythm was PEA. CPR provided by paramedics was done 80% of the time in these children. And children needed to be intubated, and epinephrine was used most often, which of course in PEA would be your only drug that would be beneficial. Outcomes were not great. Very often, a lot of these folks deteriorated, and if they required epinephrine, then that was much further down. And we remember saying that if you had CPR and your survival rate making it to the ER was as high as 90% death level. They do tend to have persistent deficits with their brain in warm water drownings. And very often, even though they survived maybe to a rhythm, very often care was withdrawn because they were either near brain death or showed brain death. Anyone who did survive usually showed complete functional recovery within 48 hours of the drowning event. Other studies have just shown that withholding or withdrawal of therapy from kids who have a low probability of survival has been suggested. We usually don't do that because with children, we try everything we can. Every year, somebody fools us, so that's why we try. They fool us by surviving. So recommendations for pre-hospital resuscitation, including early intubation if there is respiratory arrest, vascular access, advanced life support medications like epinephrine, good CPR, stabilization in the emergency department, and full supportive care in the ICU for a minimum of 48 hours if we get returned to spontaneous circulation. And if there is no neurologic improvement after 48 hours, most of the time we'll withdraw support. All right, I'm gonna pause for just a minute before I go over this case history and see if there are any questions about drowning.
You can unmute your microphone to ask questions and then remute if you'd like.
I do have one in regards to I was reading something, I think it was yesterday, and now I'm a little confused. So it was talking about hypernatremia and hyponatremia, hypo being with fresh water and hyper being with salt water. So in what regards do you consider it like drowning when it's the aspiration of the water going into your lungs, and when do you consider it hypernatremia or hyponatremia?
Well, fresh water versus salt water doesn't really have anything to do with hyponatremia or hypernatremia.
Yeah.
That hypernatremia is in the blood work,
Gotcha.
which means that it's gone through the kidneys. The drowning shows that if it's a high mineral content, like a saltwater drowning, there's sometimes more pulmonary edema in the lungs of these survivors because of tissue damage. And it
Okay.
doesn't have to do anything with the the salinity as much as the tissue damage. The hypo and hyponatremia, hypo and hypernatremia have to do with levels inside the blood, not the water.
Okay. So that doesn't refer to drowning in any case. Like that's where I'm a little confused.
I've got a question if that one's done, and if I'm
Yes.
even working. I've seen a few questions on practice tests. I know we kind of talked about the associated spinal injuries,
Yes.
but it was like the questions are more specific. Are they compression, hyperflexion, hyperextension? And I mean, I always screw it up, and I guess because I think diving, you're going into water head first, more like an Olympic diver, so it would seem to be compression. But I think if I remember correctly, the answer always seems to be like hyper extension. So is it,
Right.
are most of these just like shallow dives? So they're
Most of
hitting
these
at
are shallow
shallow
dives.
angles?
Shallow dives at the top of the head. And what happens is they do hit the top of their head. They wind up with a hyper extension of their head. And it's a compression as well because you're compressing the spinal column. So it's usually both. If there's an answer such as A and C, meaning compression and hyperextension, I think that would be the most likely.
Yeah, now that they can do that to us. Thank you. Lovely. Can't wait for that.
Yep.
Another test question I've seen in our test bank has been regarding laryngospasm, how to overcome it. And the test answer is that you overcome it just with the BVM pressure. But my question is, how likely are we actually to see laryngospasm, given the amount of time into the event that we'd be coming across the patients, and then B, how to actually manage it?
Well, if you keep in mind that asthma, for example, is an inflammatory response, you're getting an inflammatory response of the lungs, and you're probably going to hear wheezing. That's why the aerosolized beta agonists would be helpful. And again, to open up those airways, positive end expiratory pressure, CPAP or PEEP would be, if they're intubated, PEEP would be done at a ventilatory setting. And if they're not intubated and they still have a respiratory drive, CPAP would be a good choice.
And one more that I've seen come up is that whether freshwater or saltwater would most likely lead, or I forget how it's worded, wind up with a greater chance of infection and sepsis. And
yeah, it tends to be saltwater, and the reason that saltwater is there's a greater osmotic difference between the high salt content aspirated into the lungs and the low salt content inside the tissue, leading to a greater osmotic differential and greater tissue damage. And the greater the tissue damage, the more likely to get pneumonia. So, but to put that in there as a question, I know they love this, but it's kind of bogus because the differences are hundreds of points, like the 0.01 or 0.02 difference. And really treating these victims the same is most important thing to do. And again, if they're survivors and it's not a drowning death, but a drowning survival, then watching them for the good 7-8 hours is important. All right, very quickly then, I'm going to move on to this history, and it's a true history, not far from here. This is in Sun River, Oregon, which is only about 10 miles from my home here. Fire rescue was called to the scene of cold water immersion. Family dog ran 30 feet from the shore onto the ice, chasing a duck behind the nature center. And the dog fell through the ice and could not get out. So then the husband walked out onto the ice to rescue the dog, and he fell through the ice and could not get out. After seeing the husband and the dog were unable to get out, the wife did the reasonable thing, and she went out too in an attempt to rescue both her husband and dog. And she left her handicapped daughter on the shore in her wheelchair. And she also fell through the ice in the same location. The daughter in the wheelchair screamed loud enough to alert a passerby who called 911. And paramedics then showed up in the great gear that they have. And they got to the scene and they found 3 patients emerged about 30 minutes from shore, and they used throw bags and a ladder, and were able to reach the husband and the dog. They held on to the dog. The husband held on to the dog as they were both pulled to safety. The husband and wife were transported to local hospital. Husband's core temperature 89.4, the wife's core temperature 91.4. Dog was unknown because he just shook the water off and was fine at the scene. So there's a couple of clues here. Average dog weighs about 60 pounds. Average husband weighs 190 pounds. And if the surface of the ice can't tolerate the weight of a dog, or a husband, what's the likelihood that the ice would be able to tolerate the weight of the average female, 135 pounds? When you get some of these near drowning victims, you want to make sure you, in the emergency room, this is what we do. We'll make sure the C-spine is cleared, and we already had that discussion. We begin laboratory studies and chest x-rays and EKGs. High oxygen on all patients. If we need to intubate, we'll use positive pressure to open up those alveoli. We might put in a nasogastric tube or Foley to monitor input and output so we can watch their volume status and their temperature and look for other injuries that are very important. Tips to live by: learn to swim, and always swim with a buddy and never alone. Alcohol and swimming don't mix. Look for the terrible twos of being too tired, too cold, too drunk, and too far from safety. Always wear a flotation device if you're in a boat. Learn CPR often. Don't leave children unattended, which means emptying wading pools and buckets after you use them. And don't overload a boat, and make sure you have the proper equipment. And that's it. Are there any other questions? Otherwise, Jane, I think everybody asked a question.
I had one more, if it's okay.
Sure.
On you have the person that's rescued, they don't have any symptoms, so you're taking them in just as a precaution. Should they also be getting high oxygen, even if their oxygen levels are okay?
Yeah, one of my slides said oxygen for all comers, and I would just give them oxygen as much as possible.
Okay, yeah, that makes sense, especially with the hyperthermia, or in case they go bad later.
Yes.
Anybody got anything else out there?
Sir, you talk about a couple places we're talking about drowning and another places we're talking about submersion. Is there an actual clinical difference between the two?
No, not since 2002, when the World Health Organization looked at this. Submersion and drowning are all the same. That's water in the lungs. And the term near drowning, even though we use that for survivors, or dry drowning, there was some feeling that there was a laryngospasm that closed the glottis and no water got in. That just doesn't happen. So drowning and submersion are the same thing.
Thank you, sir.
All right, very good. Thank you, Jane.